let's keep this definition. So remember this kind of broad overview. So today we discuss lymphomas, and in the next session, about a week later, we will discuss the lymphoid leukemias. Yeah. So throughout this lecture, I like to pause in between and ask things and make clarifications. So be ready. I might randomly call upon anyone and we can discuss things. Okay, so when it comes to lymph node diagnosis, we typically use a four-pronged approach. We have tools. One of them happens to be morphology, yeah? And that's morphology. You see the pink and blue slide, that's the typical thing that we use to make any diagnosis and for morphology. And second is immunophenotype. And the immunophenotype of any lymphoid neoplasm is important. And for that, we use this extra slide called immunohistochemistry, which is something that we use on slides. And then we have cytogenetics, which has many components, including FISH and karyotype, where you probe for certain genetic alterations, and karyotype, where you look for specific global abnormalities in the chromosomes of the tumor cells. And then you do molecular sometimes. And it varies what kind of molecular you will do for what kind of cases. That's something that the pathologist will think about all the time. And you, if you are general surgeons excising a lymph node, you should be smart enough to know when to request a lymphoma workup. Because all of these features that I'm talking to you have everything to do with working up a lymphoma case, as opposed to a metastatic malignancy. So you need to have the clinical acumen to know when to request these things possibly. So the hematopathologist will make the judgment after they come and do a touch preparation of the slide in the pathology growth room. But you should be smart enough to know to request lymphoma workup when the clinical diagnosis seems to suggest it. So that's your morphology. And you can see the 2x, which is a low power microscope, where you look at it under the slide and look for patterns. A lot of lymphoma diagnosis is actually about pattern recognition. It has nothing to do with being smart or knowing a lot. You can know a laundry list of things, but if you cannot recognize patterns, you're not going to be able to make a diagnosis there. So this is the pattern under the microscope when you look at low power. And so here we are seeing rounded structures. So this is a pattern that you should be able to pick on. There are 4 rounded structures. And so this corresponds to a possible nodular proliferation. Mind you, I didn't say lymphoma, because I don't know that this is lymphoma unless I actually do stains or have any phenotype on this slide. Yeah. Let's see. There's a chat. Let's convert this chat here. Oh, okay. This is Dr. Kanagil saying bye. Fine. Okay, that's that. And these are your nodular structures. So this is what the pathologist needs to be smart enough to recognize. And the rounded structures that you see here, over here and here, are empty spaces, which are basically fat molecules. This is how fat looks under the microscope, and it's usually easy to recognize fat. And when lymphoid tissue creeps in between the fat, that's never good. That probably corresponds to a lymphoma. That's something to remember. And that's your cytology. When we go slightly into higher power and look inside one of these nodules, like maybe this area, this is how it will look at high power. And here you see all the constituent cells of the lymph node over there. So you need a baseline reference for what you're going to call normal. So your ability to recognize a normal cell is critical. So when we look at a cell, these are lymphoid cells that are normal cells that are rounded. And these probably correspond to the background T cells. Of course, I cannot say that with certainty. This preparation, this pink and blue preparation is called hematoxylin and eosin. You guys probably know this. And in reference to these small lymphoid cells, which are these guys, these cells are larger. And so these larger cells are called centroblasts. And so when there are too many centroblasts in a lymphoid follicle, that can't be good. And if they form a funny pattern like this, that also cannot be good. So we are thinking of some lymphoma. So this is how we approach. Low power, I see nodules. High power, I see centroblasts. And then I see too many centroblasts. That equals one diagnosis. Let me confirm that with an immunostain and then you get to a diagnosis. So with that said, we do immunophenotyping in two ways. So this is an immunostain slide, and we tag an antibody. This is a primary antibody, and that's the fluorochrome that we use. This is usually bright field microscopy. So this is immunohistochemistry. This is how it works on tissues that are fixed on slides like this, lymphoma tissue like this. And this is how it looks under the microscope, where your cells are positive for the red thing in the cytoplasm of the neoplastic cells. The second is in suspension. So when you get a lymph node biopsy from Dr. Kanagwale, and you slice the lymph node and you scrape the lymphoid tissue when it's fresh and put it in suspension in maybe a media. You know, one of the media that we use is RPMI media that holds the cells. And then you do suspension of cells, and then you do fluorescent tagged antibodies, because on the cell surface of lymphoma cells, you will have certain antigens that are there. And depending on what antigens there are, you're able to decipher what kind of a cell it is. Yeah. So here is an example where we have tagged for this pan-hematopoietic antibody CD45 and for this B cell marker called CD19. So when 19 is 41 positive and CD34, which is an immature B lineage marker, it equates an immature B cell, which is lymphoblastic. So this is how we do flow cytometry. But again, you probably have gone through flow cytometry when you did pathology. So I'm not going to belabor that further. And of course, you have cytogenetics, where on the left, you see all the chromosomes under the microscope. You just make the cells proliferate, and then you see the chromosomes and the breaks, and then that tells a story. And if that doesn't tell you a story as yet, you can always do probing for certain chromosomal regions and look for fusions and splits. So this is for IGH-MYC. So IGH and MYC are all relevant for a lymphoma called BURKITT lymphoma. Yeah? So that's that. And so fourth is molecular. So where we do PCR for immunoglobulin heavy chain gene rearrangements. So as you would know, if cells are tumorous, if there are B cells that are clonal, then they're all going to have a very similar IGH region amplification, and that shows us PCR positivity. And we are not going to get into the nitty-gritty of PCR for lymphoma diagnostics right now, because that's not the focus. So this is gene rearrangement, the southern blot. And in the old days, people used to do southern blot, and it's still relevant for a lot of diagnosis, but not for this. These days we do capillary electrophoresis. And of course, expression profiling is not critical in the current day and age for clinical diagnostics. But we know that there are certain subtypes of lymphoma, like which are GCB, germinal center-like, or activated B cell-like, and that distinction is relevant to predict outcome in these patients. Although the initial therapy for these patients may be the same, the choices of therapy for relapse are different. So that brings us to the question of why are we dissecting so many lymphomas? Because therapies are slightly different for certain lymphomas. So the first question always is, even if it's lymphoma, does it need to be treated? Okay, that's a very big question that lymphoma people will want to know. More than half the time in low-grade lymphomas, even if you have a diagnosis, they don't treat with chemo unless it's symptomatic. So you have to remember that not every lymphoma needs to be treated. And when it does need to be treated, there is always a low-dose chemo type therapy, and there's also a chemotherapy that's big guns and really strong chemotherapy. So certain lymphomas need strong chemotherapy at the get-go. So the distinction of the lymphoma matters, and so you guys do need your pathologist to make that call properly at the get-go. So these are all things that we can use. Okay, so when the lymph node biopsy gets done by Dr. Kanagwale's team and it comes to the operation, from the operation theater to the pathology gross room, so the pathologist looks at the lymph node and has to triage. Okay, so he cuts the lymph node and he touches a small piece of the lymph node onto a slide and he aderizes it, he or she rather, aderizes it, and then they go on to stain it with bright Giemsa, and we look at it under the microscope then and there when it comes to the pathology gross room. And sometimes we will be able to say if it's a metastatic malignancy when we do the touch prep, like a cytology. And sometimes we can't say. So we triage depending on that. So we do this part where we take a portion, fix it for morphology, we isolate cells and for cytogenetics and put them in cytogenetic media, and we take cells and use it for flow, and of course we can snap freeze tissue too, especially if there is a research interest by certain groups, provided you have the right approval from the research review board. You can snap freeze and use it for molecular and things like that. Especially when you want to do RNA type work, you want to snap freeze tissues. Getting decent RNA out of formalin fixed paraffin embedded tissue is not the easiest, and the quality of RNA that you get out of a fixed tissue is pretty low. So it's always good for you to know when it's going to be lymphoma and tell them, hey, maybe you should snap freeze and you might need RNA later for research. Especially if you are a clinician investigator, then you need to be aware of these issues. With that said, let me move into normal lymph node biology. I'm not sure I'm going to be able to finish this whole thing in the stipulated time frame, but we'll get through some of these things. So I like to discuss a little normal lymph node anatomy before I jump into the gazelle lymphomas. So this is a typical lymph node with the outer cortex containing lymphoid follicles where the B cell areas are separate, and there's a paracortex where the T cell areas are there, and you have your medullary cords and sinuses. And then you have efferent lymphatics out here. You have the afferent lymphatics draining into the subcapsular sinus there. A full discussion of this requires a decent knowledge of immunology. We will try to think of immunology to some extent as we go through this. So now bringing that into the microscope, this is how it looks. You have all these lymphoid follicles, and you have all these starry sky appearance, which are basically tingible body macrophages inside B lymphoid follicles. This is how it looks under the microscope. So anatomy of the B cell zone. It's important to realize the anatomy of why B cells are separate from the T cells in a lymph node. So this is the B cell zone, a rounded structure where this follicle is a secondary lymphoid follicle, where you have a dark zone and a light zone like that. There's a reason there's an organization like that, and for anybody who has interest in immunology, you can reach out and we can discuss all of this further, and this together is called the germinal center. I'm not going to discuss the biology of how cells get into the germinal center and dark zone and light zone, because that's beyond the scope of this talk. This is where the naive B cells sit, and this is called the mantle zones. So if you ever go into pathology rotation and want to recognize areas, you should know. This is the germinal center, this mantle zone, and together the structure forms the secondary active lymphoid follicle. And beyond that, you have an area called marginal zone, where memory B cells will sit after an initial antigen encounter. And so this is how the germinal center looks. Yeah, those big ugly looking cells here that you see are the tingible body macrophages. There's a lot of proliferation going on inside the germinal center. And when that happens, there are cells that are dying and there are cells that are growing. When there's a lot of growth and death in one area, then you will have macrophages that have to sweep up the dead people. Yeah. So that's why these macrophages exist. This is called the tingible body macrophages. So that's that. And of course, so now to backtrack and look at what B cells do and where B cells develop from, I like to think of B cells like this. So B cells develop in the bones, go to the blood, and sit in the B lymphoid areas. So I call it as the sojourn of the B cells from the bones to the B zones. Yeah. So you have to know that normal B cells develop from the bone, and they become virgin B cells. They come to the blood, and they go to the lymphoid follicles, and they sit in the mantle zones that I taught you about. And then, of course, from the mantle zones, there's a big process that undergoes into the germinal center and comes out into the marginal zone as either the memory B cell or transforms itself into a plasma cell. Yeah? So this we can discuss in a different talk, but this is how the normal paracortex looks on the left side versus the germinal center on the right side. Okay, you have scattered interdigitating dendritic cells, and in the follicles you have these tingible body macrophages and certain other kind of dendritic cells that are called follicular dendritic cell. Yeah. So down here, this is one follicular dendritic cell. That's how it looks. It looks like two nuclei just touching each other or kissing each other. So that's how your FDC looks like. And this is how the medulla looks. And when all the plasma cells have formed from the germinal centers, they come out in the medullary cords and sit right next to the sinuses. They sit right here just because the plasma cells produce immunoglobulin. Immunoglobulin can get into the efferent lymphatics and just get into the blood, because that's how your serum immunoglobulins come about. So that's that. And this is the final bird's eye view of how the normal lymph node looks like before we go to the abnormal stuff. You have the cortex of the lymph node, you have the reactive secondary lymphoid follicle, you have the mantle zones, and then the antigen comes into the subcapsular sinus. It encounters the B cells, go through a lot of reactions over here, and then finally the plasma cell forms here and starts moving the medullary cords over here, and the plasma cells secrete immunoglobulin that comes into the efferent lymphatics in this area, and then they go out and they get into the serum. That's how the lymph node forms. So it's good to remember this global anatomy of a lymph node. And again, this is mostly for pathology folks who have interest in pathology that need to remember a lot of this, but it's good to know from an immunology perspective one way or the other. So now, having discussed the scope of normal, it's good to know that the abnormal is actually just a caricature of normal. And on the top left over here, you can see follicular hyperplasia, where the follicles are really big and big and big. Bulk of the lymph node actually seems to be follicles. This happens when the B cells are proliferating inside those follicles and are not able to find the best fit B cell for a specific antigen at hand. So that's that. And so this happens in certain diseases. There are certain other diseases where the T cells are going to react a lot and the follicles won't really react much. And the T cell areas will totally compress the follicles like these. That's called paracortical hyperplasia. And there are certain diseases where the follicles are kind of normal, the T cell areas are normal, and you tend to have a lot of plasma cells populating the medullary cords. And obviously these plasma cells are ineffective. Last but not the least, you have histiocytes, the paracortex, that will become really big. And there'll be sinus histiocytosis that often occurs in certain conditions. And there is a reason why all of these separate kinds of reactions might occur. They can sometimes occur in combinations in certain diseases. Follicular hyperplasia, I think somebody needs to mute their screen. Okay, so that's that. Okay, let me go back to there. Okay, F5, screen. Okay, you can see my screen, right?
Yes, sir.
Okay.
Yes, sir.
Okay. So that's full screen then. Okay, fine. So that's follicular hyperplasia that occurs in patients who have rheumatoid arthritis. And then, of course, this is early HIV, where there's extensive follicular hyperplasia. Okay, so in HIV, there's extensive follicular hyperplasia because the virus keeps changing its phenotype, right? There's a lot of antigenic change. Because of that, the follicles are not able to keep up and make a HIV-specific, antigen-specific B cell. The moment the follicle makes a proper B cell, the HIV antigen is changed again because of mutations. And then the B cell follicle starts making an antigen all over again. So that's why you tend to have giant follicles in early HIV. And after a point, these follicles cannot keep up and they just die. And when that happens, we call it follicular lysis. Yeah, so that's that. And this is sinus histiocytosis, where you have a lot of histiocytes around the sinuses in the lymph node. And this happens especially after you have a surgery and there's a draining lymph node in the region of the surgery, and that starts enlarging because there's a lot of lymph and a lot of debris that the lymph node will handle from the surgery. And so that manifests as sinus histiocytosis. So this is something you would see in patients who have had dissections. time and again, surgical pathologists will come and show these lymph nodes to the hematopathologist and say, hey, with this, there's a lot of pink stuff in the paracortical areas. What is this? Is that maybe a malignant proliferation of histiocytes and things like that? When we look at it, we will typically ask the question, did the patient have a recent surgery? Try to look for it, and they'll say, of course, this is a recent post-surgical case. Then let it go, we won't do anything. This is one more case where the patient has psoriasis. And when you look at lymph nodes of patients who have psoriasis, you will see a lot of this pigment-laden macrophages, all the brown stuff that you see inside the histiocytes. And anybody want to take a guess what the brown stuff is? I don't know if you guys are able to do a chat thing at all or not. Okay, I guess not. Okay, this is melanin. Yeah. So that's that. And so far we looked at overview of normal lymph nodes, normal histoanatomy, the organization of cortex, medulla, germinal centers, and paracortex. We looked at abnormal reactive, and things we looked at was follicular hyperplasia and sinus histiocytosis and dermatopathic changes. It looks fancy, right, that word? But that's the pigment accumulation in patients who have skin diseases. So now, with this knowledge, you can move on to lymphoma. So you're ready to learn lymphoma. So lymphoma, when you look at the WHO book or any list, it's a big laundry list. Yeah. So knowing each and every lymphoma is not the most critical thing, but knowing which are the bad players is probably more important than anything. And so you need to know as pathologists which are the bad players and how to recognize the bad players. That's all you need to know. So when we look at lymph nodes, we use some very few simple tools. One of them is, are there few malignant cells in the lymph node? And are they malignant cells? These are two questions we always ask ourselves. So are they malignant cells? Because there can be some mimics that are not necessarily malignant. And so that can be a confounder. If it is, and you're convinced, and if you can get one more colleague of yours to agree, then you're probably dealing with one of two Hodgkin lymphoma subtypes. Yeah. And if there are numerous lymphoma cells all over the place, then you're probably dealing with one of the gazillion non-Hodgkin lymphoma subtypes. So this is as simple as it gets. And then you can weed through the laundry list of non-Hodgkin lymphomas and try to find the right name. But again, common things are common. So don't think esoteric stuff when common things are common. So this is Reed-Sternberg cells on the left, also called Sternberg-Reed or Reed-Sternberg. You can call them whatever you like. They are this fat alloy nucleoli. This is something that was described initially by Thomas Hodgkin back in the 1800s. And then later in early 1900s, two other people. There's one German person, and then there's this lady from Johns Hopkins University called Dorothy Reed. Both of them pretty much described these cells in the specific lymphoma. And so these cells are called Reed-Sternberg cells. And before Reed-Sternberg, we sometimes will say Hodgkin/Reed-Sternberg cells. Which then brings us to the classical Hodgkin lymphoma. And this is the most common subtype that's seen in the West. I don't believe this may be the most common one in India, because there's a different one called mixed cellularity that's probably more common in India and the East. So this classical Hodgkin lymphoma, nodular sclerosis, will show a lymph node that has a lot of pink stuff like this. Yeah? So this is very common with classical Hodgkin lymphoma. And you have nodular structures that don't look very different from your lymphoid follicles. And when you look at high power, you will see these large, ugly, multinucleate or uninucleate cells. And these are called Hodgkin cells, otherwise lacunar cells. In this specific subtype, the Hodgkin Reed-Sternberg cells are called lacunar cells because they look like they are floating inside a lacunar pool. Lacunae means a space. And the space is actually a retraction artifact created by formalin fixation. So suffice it to know that if you see eosinophils, multinucleate cells like that, and lacunar cells, then you're dealing with a classical Hodgkin lymphoma. So with that said, you will also see some other cells called mummified cells, which look like that. Basically, the cells have dark nuclei, they're dying, and they're getting mummified. So these are mummified cells, which you sometimes see in classical Hodgkin lymphoma. And there's a good reason why cells mummify. Cells' mitotic machinery is kind of gone bad in Hodgkin cells, which actually are B cells. And when the mitotic machinery is gone bad, the cells tend to die and they kind of mummify like this. And that's why you see these kind of dark cells in classical Hodgkin lymphoma. And this is an immunohistochemical marker called CD30. And on the right, you see CD15. These are two markers that are positive in the Hodgkin cells in classical Hodgkin lymphoma. And of course, when we look at lymphoma cells, we like to know if they are a B lineage or T lineage. So now classical Hodgkin lymphoma actually happens to be a B lineage lymphoma. And we know that, we can prove that by showing that they are positive for this marker called PAX5, which is weakly positive in the Hodgkin cell like this, as opposed to normal small B cells in the background, which express bright PAX5 like that. I shouldn't call it bright, it's moderate. So you always have your internal reference to compare things to in immunohistochemistry. And you should be aware and note these things on your reports as a pathologist, discusses stains. So a good pathologist would probably be able to say that in this case, the Hodgkin cells express weak PAX5 with surrounding background cells expressing moderate to bright PAX5, which is the expected pattern. And so this comes from that brown slide that I showed you, which is immunohistochemistry, which is pretty much confirmatory for classical Hodgkin. So basically, bottom line, morphology, look for diagnostic Hodgkin cells. The phenotype, they are positive for this PAX5, which is a B lineage marker, but they are negative for one B cell marker, which is called CD20. CD20 is a mature B cell marker, and this is almost most of the time negative in classical Hodgkin lymphoma, because even the B cell machinery is kind of deranged at the genetic level in Hodgkin lymphoma cells, in classical Hodgkin lymphoma rather. And yet, we know that Hodgkin lymphoma cell arises from a B cell in the germinal center. So this is your Hodgkin cell there. Those are your PAX5 positive surrounding B cells. You don't need cytogenetics really to make a diagnosis of Hodgkin, and you don't need molecular studies. So this is why how you triage the lymph node in the growth room is critical. If you clearly see Hodgkin cells, you're not going to go chasing with molecular and cytogenetics. So be careful about how you use molecular studies. And a subset of them will express EBV like this. And EBV positive Hodgkin's is fairly common in India, and the Hodgkin cells will be positive there. That's because of the immune status of folks are slightly different, the composition, and therefore you see EBV positive Hodgkin's more common in the East compared to the West. Now with that said, there is one more flavor of Hodgkin lymphoma, which is called nodular lymphocyte predominant Hodgkin lymphoma, where you again see few scattered cells here and there, and these cells are not called Hodgkin cells, but we call them as LNH or LP cell. They are called L&H because they keep the company of lymphocytes and histiocytes. And the LP comes from the word lymphocyte predominant, because the background predominantly has lymphocytes. And we also have one more name for these cells and call them as popcorn cells. Yeah, that's that. Okay. Oh, I'm sorry, I'm just seeing the chat now. Senna has said melanocytes, so that's very good, very good. So that was in response to the previous question I had asked. Okay, let's keep moving. And so the basic idea is few malignant cells, look at the cells, they have fat nucleoli, they are positive for 30 and 15 and lack 20, your Hodgkin cells or classical Hodgkin lymphoma. The nucleus looks like a potato and small nucleoli, they're 30 negative, 15 negative, 20 positive. See, this is CD20. There are positive in the large cells of nodular lymphocyte predominant Hodgkin lymphoma. And these are not called Hodgkin cells. So you have to remember this. So the exact opposite phenotypes, if you don't remember anything, this one slide sums it all for you. So this is how you diagnose classical Hodgkin lymphoma. You basically need just 3 markers. In all honesty, you probably don't even need immunostains to diagnose Hodgkin lymphoma, but you do have to use it to confirm it. because there's a whole lot of other lymphomas these days that can have scattered Hodgkin-like cells that have nothing to do with lymphoma. So again, recapping what we learned so far, we learned about reactive and the patterns of reactive. We went down to lymphoma, and then we looked at the two kinds of lymphoma, Hodgkin, non-Hodgkin. And within Hodgkin, we learned that there is classical and there is nodular lymphocyte predominant Hodgkin lymphoma. Yeah. Now, then the other half is non-Hodgkin's lymphoma. So any questions so far? Anybody? You can't all be quiet. You have to answer something. Okay. Okay, let's see. Okay, this chat question. Let's see who answers first. You're able to see the question there? All of you? You can do a private message or a public message. I don't care. Let's see if you can get the right answer. Anybody quick? CD15 is positive in which lymphoma? That's the question I wrote in the chat box for you guys. Okay, Shweta has already replied. Classical lymphoma. Classical what lymphoma? The name. Good. Classical Hodgkin lymphoma. Yes. You have to be a stickler for the exact names. Yeah, that's wonderful. Yeah, and Shweta said that too. Oh, there's a lot of Hodgkins coming. Yeah, Anirudh Balaji, you're right too. Shweta, that's good. So now you all know Hodgkins. Okay. So with that, we come into the laundry list, which is non-Hodgkin's lymphoma. Yeah, this is the 2017 WHO. The recent classifications arrived, and this is how it looks. The latest classification. It's a big fat book. It's 2 times the size of the previous edition. There's a whole lot of new entities. So these days you have to know a lot more. So this is the WHO classification of all the lymphomas. It's a big laundry list. Truth is, you don't need to remember the big list. B cell processes comprise 80-90%, and T cell processes comprise a very small proportion. It may be slightly higher on the east, but they are a small proportion. So we will discuss some of these entities that would cover 80% of what you would see in real life. So again, we go back to patterns. And I told you, if you see few large cells, you're talking Hodgkin subtypes. If you're seeing numerous large cells, you're talking a non-Hodgkin subtype. So here we see a diffuse proliferation. Yeah, this doesn't look anything like a normal lymph node. And you can even see at this cover, there's some funny structure over here. And this is a mitosis. And you don't want to see mitosis like this with sheets of cells. So you should be able to recognize a diffuse proliferation like this. And here we see a nodular proliferation of cells. Yeah. So this is pattern recognition right here. And then we move on. When we see it's diffuse, we try to decide if these are small cells or large cells, and if they are large cell cleaved, or if they have large cells with fat nucleoli. A lot of cells can have nucleoli, not only Hodgkin cells. So you should remember that. And so you have to be careful about what you're dealing with when it's diffuse proliferation. And a few subtypes that we will discuss here are these 5 pretty much comprise 90% of what you would see in your real life. Yeah. So we will discuss some of these subtypes and how to get to the diagnosis in these cases. So indolent lymphomas. These 3 guys are indolent. Small lymphocytic lymphoma, or otherwise known as chronic lymphocytic leukemia, marked lymphoma, follicular lymphoma. Yeah. Are low-grade lymphomas or indolent lymphomas. And then the red guys, diffuse large B cell and BURKITT, are the bad players. So these, when you make the diagnosis of these 2 guys, pretty much they need to be treated. It doesn't matter whether the patient is symptomatic or not. Yeah, that's a decision that lymphoma people will take. So especially when a pathologist, many times he's communicating with the surgeon. So when the pathologist sees the diagnosis of BURKITT or diffuse large B cell, he will quickly tell the surgeon, hey, make sure that the patient gets an oncology appointment as soon as possible, because this requires treatment as soon as possible, and the patient is going to deteriorate anytime. So the surgeon is aware of how acute your diagnosis is and will make the appropriate referral in time. If you just put out a report without having a conversation with the surgeon, then you're not doing good service to the patient. So you have to remember to think ahead when you get bad diagnosis under the microscope as a pathologist. These are aggressive lymphomas. So let's discuss the morphology of small lymphocytic lymphoma. It's a diffuse proliferation, and the cells look like this. And at this power, I don't know if the cells are small or large. So I will have to do a size comparison with these T cells. Now at this power, I can see that the cells are actually small, very small, and they have small dark nuclei. And typically they'll be CD5 positive, 23 positive. Yeah, let's see, we are 7:15. I think we need to ramp our speed up a little more. If need be, we'll continue in the next class. And typically, CLL is positive for CD5 and CD23. These are two immune markers that we typically use, and we might even use flow cytometry. The cytogenetics and molecular are useful. There is some prognostic value, but we do not routinely do all the time, except for P53 deletions. We sometimes do FISH if we need to treat CLL. And this is a marked lymphoma where there's a salivary gland here, and it's being infiltrated, the glands, by monocytoid B cells. And this is an epithelial stain showing the lymphoid cells getting into the glands and destroying it. This is a B cell stain showing B cells inside those glands. This is how a marked lymphoma occurs in GI tract, salivary gland, or lung for that matter. Yeah? And then we move on to follicular lymphoma, which is probably also very common. And this is a nodular follicular lymphoma. So I've been showing you this slide time and again to recognize the nodular pattern. And in comparison to a reactive follicle, which shows a mantle zone and a germinal center, you won't see the distinction in the neoplastic follicular lymphoma follicle. Just because two things look round, they are not one and the same. You should know that the patterns are the patterns. And you should know distinguish reactive from malignant. And you see tingible body macrophages here, whereas you won't see any of those guys here. Because in follicular lymphoma, even though it's lymphoma, there is no proliferation going on. And this is how your cells of follicular lymphoma look. They look very squiggly and cleaved, and they are called centrocytes. And we like to grade follicular lymphomas depending on the centrocytes and the ugly cells called centroblasts. And this is grade 1, and on the right side I show you a grade 3 with large cells. And they're still follicular because they retain the nodular pattern. Yeah, this is normal lymphocyte for comparison in both situations. And now you know how I compare the lymphoid cell size with the surrounding cells. So you need an absolute reference all the time. This is how follicular lymphoma looks, the malignant follicles, yeah? And usually the follicular lymphoma cells are positive for CD10 and they express BCL2. And they express this anti-apoptotic protein called BCL2 and they just don't die. And this excess BCL2 occurs because there's a translocation involving IGH and BCL2, where the BCL2 gene on chromosome 18 jumps from chromosome 18 and goes and sits next to the heavy chain gene, which is on chromosome 14, right there. And when that happens, the heavy chain promoter will drive BCL2 secretion and increase BCL2 levels, and the cells just don't die. So follicular lymphoma is a disease of undead cells. It is not a disease of proliferation. So when we do a proliferative marker like Ki67 in follicular lymphoma, the follicles won't show high proliferation. Okay, and this is how follicular lymphoma cells look like in the blood. Okay, so this is a long cleavage running to the cell, and so we like to call them as buttock cells. Yeah, and in the bone marrow, when they infiltrate, follicular lymphoma cells like to cling to the bone. They're very clingy cells. They like to be like that. And a B cell marker called CD20 can highlight the B cells around the paratrabecular areas. This pattern of infiltration is very characteristic. And so when a bone marrow biopsy is done, I can easily say, this is going to be follicular lymphoma. Let me do CD20, 10, BCL2, and then I have a diagnosis. This is diffuse large B cell lymphoma. Yeah, and that's how it looks. Sheets of cells. There's a lot of macrophages here. And I see a structure over here. Anybody want to guess what structure I have highlighted in this area? You can do the chat. Okay, Shweta, Anirudh Balaji, anybody want to try? Come on, quick, we don't have much time. This is a structure in the normal lymph node that you would see sometimes that I have highlighted. What have I highlighted here with double arrow marks, double question marks? Wonderful, reactive follicle is what Shweta says, and she's perfectly right. And to qualify this further, it's a reactive secondary lymphoid follicle. Yeah, so that's good. So yes, so you're right. And so diffuse large B-cell lymphoma, you see large lymphoma cells, and this is your small lymphocyte. So every time I show you large, I will show you what is normal. And this is what pathologists need to do all the time, because guessing cell size always has to have an internal absolute reference to compare cells to. And you need to be good enough to do this practice all the time when you're making diagnosis. And of course, it matters whether the cells are CD10 positive or not in diffuse large B-cell, because expression profiling is shown that the activated B-cell subtype tends to respond a little less well to standard chemotherapy that they give for diffuse large B-cell lymphoma. Do any of you know what they give for diffuse large B-cell lymphoma up front? What is a common frontline therapy for diffuse large B-cell? If you guys have done medicine, you might be able to say this. Any idea? Go ahead and type it, and I'll continue. So this is a BURKITT lymphoma, where you see the starry sky with a lot of macrophages acting over here. They're cleaning up the debris. These are your lymphoma cells, and these are your BURKITT lymphoma cells, and you see scattered lymphocytes. And this is apoptotic debris and not really lymphocytes. You have to be careful. And the lymphoma cells are actually medium-sized here, believe it or not. And this is how BURKITT cell lymphoma cells look like. And this is very, very aggressive, and it's an emergency, especially for a pathologist and an oncologist. And for BURKITT, it's a B-cell lymphoma, so CD20 is positive. It is the germinal central origin, so CD10 is positive. And I told you this matters for therapy, whether it's GC or non-germinal central origin. And then, of course, this is BCL2 negative. So the lack of BCL2 is actually pretty useful. And normal B cells in the background are staining for BCL2 over here. And this is very diagnostically useful. So the combination of these three features plus 100% proliferation on Ki67 will tell you that it's a B-cell lymphoma of germinal central origin with 100% proliferation. So this is bad. And BURKITT lymphoma happens because there is a translocation of the MEK oncogene that goes and sits next to the heavy chain promoter. So I already told you that there's one more lymphoma where the gene goes and sits next to the heavy chain promoter. What other lymphoma was it? Anybody wants to go ahead and do the chat thing? Tell me while we are discussing this. So there's MEK rearrangement because a part of chromosome 8, which has MEK, will have that gene go and sit next to the heavy chain promoter on 14. And the 14's heavy chain promoter will drive the secretion of MEK, which is an oncogene, which drives proliferation in BURKITT lymphoma. And this is, last but not the least, this is a T-cell lymphoma. Yeah, I'm not going to discuss every single T-cell lymphoma, but one that you should know that can confound people is the anaplastic large cell lymphoma. And it's actually a T-cell lymphoma, and yet it's negative for pretty much all T-cell markers. And often you will see the lymphoma cells inside the vascular spaces, they resemble emboli. It's carcinoma-like vascular emboli. It's a typical feature. And even when they do a frozen section, time and again, people will do frozen section, and the frozen section diagnosis on an anaplastic large cell will be metastatic carcinoma. And when the final sections come and they work the case up properly, they will realize that the cells inside those vascular spaces are really not carcinoma cells, but rather lymphoma cells. So this is one lymphoma that likes to creep inside blood vessels like this. And it's a very scary diagnosis. And often the surgeon gets very angry when they hear the final diagnosis changeover from metastatic carcinoma to a lymphoma. And they have a hard time wrapping their minds around why the diagnosis changed. And they think it's an incompetent pathologist. But truth is, you can only go so far with your frozen sections. And then we deal with that. So that's the anaplastic large cell lymphoma at high power. You can see how big and ugly the lymphoma cells are with mitosis and stuff. And so that's how it looks. And of course, the important marker is CD30 that we do here. And what you see here is sheets of CD30 positive lymphoid cells. That's important in anaplastic large cell lymphoma, as opposed to one other lymphoma where we saw CD30 being positive, which is classical Hodgkin lymphoma. But there you saw few scattered cells positive for 30, not sheets of 30. And again, there's a translocation in this lymphoma that's driving all this proliferation. Let's not get into the nitty-gritty of what this translocation is. There's a gene called ALK, and that's why it's often translocated in these cases. And pretty much young patients with ALCL will be ALK positive, which is generally has a slightly better prognosis if it's diagnosed properly. But problem is ALK positive ALCLs often don't get diagnosed in time because it gets misdiagnosed, maybe as carcinoma or sometimes even as appendicitis. I have a case of a kid where they thought it was appendicitis and they removed the appendix, and lo and behold, you see that it's actually ALCL, because this has an ability to produce paraneoplastic GCSF. And when that happens, there's a lot of neutrophilic response in the blood with neutropenia, and you would think just an infection and appendicitis, but in reality is the lymphoma driving the proliferation of neutrophils. It's very weird, and it's also fascinating at the same time and scary, because there's a potential for misdiagnosis at the clinical level, at the pathology level, and at multiple levels it can get misdiagnosed. So that's a problem with ALCL. And you can do a marker called ALK or ALK protein, which is overexpressed in these lymphoma cells. And here you see a reactive follicle is negative for ALK. So this is how your ALCL looks like. So I think with that, we'll do a quick bird's eye view of the, look at the HNE, and this is your standard approach for any lymphoma. Is it reactive? Is it effaced? We will make this distinction just looking at the tissue. And if it's reactive, the game ends. You stop chasing things further. Whereas if it's effaced, then you go further and try to look and see what cells are we seeing. And if you see layered large cells, then you're talking of doing immunohistochemistry for 30 and 20. And if it's 30 positive and 20 negative, what lymphoma is it?
DLCL.
Yeah, you said something?
DLCL.
Sorry?
DLCL.
No, Hodgkin cell.
Hodgkin lymphoma.
Hodgkin lymphoma. Very good. Yeah. So it is rare blood cells, 30 positive Hodgkin cell. Look at the fat nuclei. I showed you that.
Okay.
And if the phenotype is the opposite of this, 30 negative, 20 positive large cells here and there, what could it be?
Non-Hodgkin.
Very long name.
Non-classical Hodgkin.
Yeah, you're right. Non-classical, it has a long name. Nodular lymphocyte predominant Hodgkin lymphoma. Even though the name Hodgkin is there, Hodgkin did not describe this lymphoma. Yeah? Potato-like nuclei. Yeah? The left one is like an omelette, the right one is like a potato. And if it's a uniform population, if it's nodular or diffuse, look at that, do the math. If it's 10 positive, then you're thinking of follicular lymphoma, nodular proliferation. If it is a diffuse proliferation, you're thinking, and small cells, a CLL or marginal zone lymphoma. And if it's medium to large cells, then you're talking of the bad players, BURKITT lymphoma or diffuse large B-cell lymphoma. So that's it. This is all you need to know for lymphoma. And as long as you remember this equation, you're fine. And I think I'll stop at that because we have one more nice lecture coming up. So yeah, any questions?